Today we will start with some of the diseases caused by infections due to protozoa, and most important among them is malaria, which is caused by infection by members of the genus Plasmodium. This is the most important parasitic disease of humans. This is because it causes hundreds of millions of illness in the world and about 1 million deaths each year all around the world. The disease is endemic in most of the tropics, including much of South and Central America, Africa, the Middle East, the Indian subcontinent, Southeast Asia and Oceania, including the Papua New Guinea. This is because the environment in tropics is more suitable for breeding of the mosquito vector, which is Anopheles. However, transmission, morbidity and mortality are greatest in Africa. This is because the most serious form of the disease, that is Falciparum malaria, is highly endemic in Africa. And there also young children at high risk for severe disease from Falciparum malaria. But in areas with low endemicity, individuals have low immunity and symptomatic disease may occur at all ages. Here we need to understand this point of endemicity with the presentation of disease. Endemicity is described in terms of rates of splenomegaly in children 2 to 9 years of age in that area. If the rate of splenomegaly in such children is less than 10%, the area is called hypoendemic. 10 to 50% is mesoendemic, 50 to 75% is hyperendemic, and more than 75% is holoendemic. In highly endemic areas, there is intense transmission of the disease throughout the year, and every person has a risk of more than 1 bite per day by an infectious mosquito, or you can say more than 300 bites per year by infectious mosquito by an individual. So the main burden of disease, morbidity and mortality is faced by young children who have less immunity against the disease, and in fact about 90% of total deaths of malaria occur in young children in these areas of Africa. However, if they survive the adulthood from disease and go into the adulthood, due to repeated infections by various species of Plasmodium, they acquire sufficient protective immunity against the disease so that symptomatic disease does not occur in adults in these areas. Indeed, patients frequently show asymptomatic parasitemia, means you can find parasite in their blood, but they will not be having any disease. This is important in continuing the cycle of the disease in the population, and the immunity is protective against disease but not against infection. I mean, they can acquire the infection but they do not develop the disease. But in areas with low endemicity, because of less chances of infection, such comprehensive immunity is not achieved, and symptomatic disease can be seen in every age groups. However, the intensity of disease may be not so severe. But if a person in the non-endemic areas acquire the disease, for example, if he travels to an area which is endemic, he is likely to get a very serious disease because not any type of immunity is existent in that person, because he had never been exposed to the disease before. There are 4 species of Plasmodium which regularly cause disease in the humans, which is Falciparum, which is the most serious and also among the most common species. Vivax is almost as common as Falciparum. Ovale and malariae infections are less common. Another species, Plasmodium knowlesi, which usually causes disease in monkeys, is sometimes known to cause disease in humans in certain limited geographic regions. But as I have already told, almost all deaths are caused by Falciparum malaria because of special characteristics that we will discuss subsequently. The disease transmitted by the bite of infected female Anopheline mosquito during feeding, and here it should also be remembered that not all, there are several hundred species of Anopheline mosquitoes, not all are capable of transmitting the disease, and those that can actually transmit also vary considerably in their efficiency of transmission of disease. Several factors are important, most important being the longevity of individual mosquito. Of course, it needs to survive the time from the time it acquires the gametocytes from a sick person, let the sexual reproductive cycle to complete in its body, and then become infectious, which is a process which takes more than 7 days to complete. So if the mosquito survives that long, it becomes infectious. Otherwise, there is no risk of infection. Moreover, different species vary in their sensitivity to ambient temperature and their preference and biting habits. Some species preferentially bite humans and some species bite animals. So all these factors are operative in determining the endemicity of a locality. Rarely the disease can also be transmitted from pregnant mother to fetus, and here the level of parasitemia is important. High levels of parasitemia increase the risk of fetal involvement, and this leads to development of congenital malaria, the most common manifestation of which is low birth weight. However, it can be severe enough to cause stillbirth. Sometimes it can also occur by blood transfusion, and in that case the incubation period for malaria is much shorter because the hepatic or pre-arthrocytic phase of disease is not present. The parasite has both sexual and asexual reproductive cycles. The asexual cycle is completed in the human host, while the sexual cycle is completed in the mosquito vector. Disease is transmitted by the bite of infected mosquito, which injects the sporozoites into the person. These sporozoites travel through blood and reach the liver, where they invade the hepatocyte, proliferate there without symptom, as this is the incubation period. Then after they complete their proliferation and the hepatocyte is damaged, it bursts open to release several thousands of merozoites, which are carried by blood and infect the red blood cells. In the red blood cells, they develop again into by their asexual reproductive cycle, develop into trophozoite, then mature to become schizont. By this time, the red blood cells also become damaged and burst open to release 6 to 30 merozoites. Each one of them is potentially capable of invading a new red blood cell and start the cycle again. When this cycle repeats again and again, and when parasitemia level reaches a certain level, patient starts having symptoms of the disease with fever and typical chills and rigors. However, during this cycle, some of the merozoites do not develop into trophozoite and asexual cycle. Rather, they develop into male and female gametocytes, which can then be taken by another mosquito during a meal, and it will start sexual reproductive cycle in the mosquito, where it will develop into midgut and form a cyst, which will insist into the wall of the midgut. This cyst then matures and bursts open to release sporozoites, which invade the cell every grand of the mosquito, which then becomes infective. So once this cycle is completed, the mosquito becomes infective and can transmit the disease to a new host. Here this cycle is completed like this. This is the infectious mosquito, which causes infection with sporozoites during meal, which invade the liver and hepatocyte, mature there into a hepatic schizont, which then burst open to release several thousand of the merozoites. These merozoites then individually invade the red blood cells, develop into trophozoite by asexual reproduction, then mature to become a schizont, RBC schizont, which then burst open to release 6 to 30 merozoites, which then again invade the red blood cycle, and cycle is repeated again and again, so that the parasitemia level starts to rise. During this time, some of the merozoites invading the red cells do not develop into trophozoite. Rather, they become male and female gametocytes, which are then taken by another mosquito during the meal, form a zygote, develop by sexual reproduction inside the midgut of the mosquito, which then becomes infective after about 7 days. Another point should be noted that only with ovale and vivax, some of the sporozoites invading the hepatocyte do not develop into schizont, rather become dormant and stay there, and these are resistant to treatment by most of the antimalarial and responsible for repeated recurrences of the disease without acquiring new infection. But this is specific only for Plasmodium vivax and ovale, not for Falciparum and Malariae. The symptoms and signs of disease start with a prodrome of headache and fatigue, which is then followed by fever, Initially, the fever is irregular, but gradually it becomes the typical cyclic pattern with chills and fevers, and then lies with sweats. The intermittent fever ultimately becomes regular with non-Falciparum species, but for Falciparum it remains irregular with the variable spikes. Fever subsides spontaneously even without treatment after a few hours, and the patient may appear remarkably well between these febrile episodes. This is associated with headache, malaise, myalgias, and arthralgia, but sometimes cough, chest pain, abdominal pain, anorexia, nausea, vomiting, and diarrhea, which are common, may suggest some alternative diagnosis, but this should be recognized. The respiratory and GI symptoms are part of the syndrome of malaria. Seizures, while febrile fits are common in young children, but seizures in adults should arouse suspicion of CNS involvement, which is a serious complication. Anemia, jaundice, splenomegaly, and hepatomegaly suggest severe disease and need active management. A parasitemia of more than 2%, that is more than 2% of peripheral RBCs being parasitized, suggests Falciparum infection, because other species, due to their specific preferences, do not reach such high level of parasitemia. So, due to this, almost all deaths are caused by Falciparum malaria. Appropriately and promptly treated uncomplicated Falciparum malaria carries a mortality above 0.1%, but if certain complications develop, for example, patients develop vital organ dysfunction or the total parasitemia reaches more than 2%, then the mortality risk rise steeply, and even with treatment, the prognosis becomes more poor. These are the certain specific characteristics of individual species. The duration of intrahepatic phase, which is 5.5 hours for 5.5 days for Falciparum, 8 days for Vivax, 9 days for ovale, and 15 days for Malariae. This is the incubation period. Then the release of merozoites from hepatic schizont is 30,000 for Falciparum, 10,000 for Vivax, 15,000 for ovale, and 15,000 for Malariae. Duration of erythrocytic cycle is 48 hours and for both Falciparum and Vivax, and about same 50 hours for ovale and 72 hours for Malariae. This is the reason why Vivax and ovale have a tertiary malaria, that is fever spikes on third day, while for Plasmodium malariae it is a quartan malaria where fever spikes on the fourth day. However, the pattern remains irregular in Falciparum malaria. The red cell preference which they invade, Falciparum actually prefers younger cells, but it can actually invade all cells of all ages alike. So this is the reason, most important reason, why it reaches very high parasitemia level compared with other species which are very restricted to their preference. For example, Vivax can invade reticulocytes and cells up to 2 weeks old, that is very young RBCs, while ovale in fact only reticulocytes, and Malariae preferentially invade the older cells. Due to these restrictions, parasitemia in these infections rarely rises up to 2%, and the disease is not serious, and most of the illness is morbidity and mortality is due to Falciparum malaria. Morphology of the ring forms and other sexual stages of the asexual stages of the parasite are also different, and they can be recognized in the peripheral smear by these features. Also, the pigment color they produce actually due to degradation of hemoglobin in the red cell is also different, so that these species can be recognized. And propensity to relapse, that is the presence of hypnozoites. This is present only for Vivax and ovale, because they can remain dormant in the hepatocyte for several months or even up to a year, and they are also resistant to treatment by most of the antimalarials. Thereby they lead to recurrent relapses of disease without requiring a new infection. However, this situation is not there in Falciparum and Malariae infections. This is the various species where they are endemic in various parts of the world. You can see that Falciparum malaria It is especially more prevalent in Central and Western Africa and some areas of the Caribbean. However, vivax malaria is more common in Southeast Asia, parts of Indian subcontinent, and Middle and Central and South America. While ovale and malariae are less common. This is the total percentage of infections acquired all over the world. You can see vivax is by far the most common, 49%, followed by falciparum, which is 36%, while malariae, knowlesi, and ovale are very much less common. Now we will discuss briefly about falciparum, because this is the most serious form, and almost all deaths all over the world due to malaria are due to falciparum. There are several features which make it unique and difficult to control. For example, the fever pattern is irregular. It is not so typical, so it is difficult to diagnose the disease clinically, because if regular pattern of tertian or quartal malaria, it makes clinical diagnosis more easy. The most important part is the fact that it can infect old and young RBCs alike, and this results in very high parasite loads. This is compared with all other species, which are very restricted in their preference to invade the red cells. Then there is another important point, that falciparum has a propensity to invade visceral capillaries, resulting in vascular occlusion and organ dysfunction and severe disease. What actually happens once the falciparum invades the red blood cell, after some time the cell starts protruding knob-like structures which ooze out adhesive molecules. This makes the red cells to adhere to the endothelium of the visceral capillaries, and not only this, they can also cause conglomerates with other infected and non-infected RBCs also. All these features lead to compromise of microcirculation and lead to visceral dysfunction. And moreover, due to visceral sequestration, peripheral parasitemia does not provide good idea of the burden of disease, because most of the parasites are sequestered into the visceral capillaries and they don't appear peripherally. In fact, sometimes they can even evade diagnosis, and you may not be able to find parasite in the peripheral blood. So moreover, this is the parasite which is frequently resistant to chloroquine. None of the other species are so much resistant, and it has the propensity to develop resistance to other drugs as well. So these are all the points which make this infection so serious. And there is one good point about it, that it has no hepatic dormant phase or hypnozoites, so that if once you treat the disease, there are no recurrences unless you acquire the disease again. There is another point, that inherited hemolytic disorders like sickle cell disease, hemoglobin C and E, hereditary ovelocytosis, the thalassemias, and glucose 6-phosphate dehydrogenase deficiency seem to provide some sort of protection against falciparum infection. Probably they make it difficult for the parasite to invade a already damaged red blood cell. So we can frequently find these traits in areas which are endemic in infection with falciparum. As I have already told, that about 90% of the burden of severe disease and death is by falciparum malaria, and is borne by young children in endemic areas, especially Africa. Repeated infections with various strains of parasite in highly endemic areas confers protection against high level of parasitemia and disease, but not from infection in adults and older children. This phenomenon is called premunition. This I have already discussed before, that this protection is acquiring the disease or high level parasitemia, but does not provide a protection against acquiring the infection. So in these areas you can frequently find asymptomatic parasitemia. Patients are having the parasite in the blood, but they do not have the disease, and this is helpful in perpetuating disease, so that the infection can be acquired by a mosquito and can be transmitted to other people who are non-immune. So this phenomenon is called premunition and is associated frequently with asymptomatic parasitemia. Both humoral and cellular immunity are important in providing this protection. Now we will briefly discuss some special features of severe disease, because that previously we discussed were the common features to all malarias, but severe disease is characterized by certain special features. As I already told, that this severe disease is usually due to infection by Falciparum, and it is characterized by signs of severe illness, organ dysfunction, or a high parasite load, in which peripheral parasitemia can reach more than even 5%, which is a very severe burden of disease. The common manifestations of severe disease are, most importantly, neurological abnormalities progressing to alterations in consciousness, repeated seizures, and coma. This is called cerebral malaria, and due to sequestration of falciparum in the capillaries of the brain, and this carries a mortality of about 2% even with treatment. Severe anemia, hypotension, and shock can occur in certain patients, and anemia is multifactorial in these people. Of course, direct effect of infection, because leading to hemolysis, it causes anemia. Then there can be hypersplenism due to splenomegaly. Another reason for anemia is that in falciparum infection, even the non-infected cells become abnormal and more tough, difficult to deform, so that their lifespan is reduced, and while they are passing through capillaries, they can easily rupture. Even non-parasite cells become abnormal. Another feature is non-cardiogenic pulmonary edema and the acute respiratory distress syndrome, which is called ARDS. This carries a particularly poor prognosis with a mortality of about 80%. Then hypoglycemia is quite common and difficult to recognize also, because most of the features of hypoglycemia are not present, and this hypoglycemia is also frequently associated with acidosis, which makes the prognosis even more severe. Hypoglycemia, as I already told, is difficult to recognize because a patient may be drowsy from other complications like CNS involvement. So it is recommended that patients with severe malaria should get their sugar levels frequently checked every 6 hours or 4 hours. And if found to be hypoglycemic, you should also think of acidosis, because it is frequently associated with hypoglycemia and leads to severe lactic acidosis, which carries a poor prognosis. There may be hemolysis with jaundice, and this jaundice is not always entirely due to hemolysis. Of course, severe hemolysis can lead to pre-hepatic jaundice, but hepatic dysfunction is also a feature of severe disease. Similarly, acute kidney injury due to acute tubular necrosis can occur, and which also carries a poor prognosis unless immediately treated. Another point is retinal hemorrhages and other fundoscopic abnormalities. Severe anemia is frequently associated with a unique type of retinopathy. This point needs to be understood particularly, because this malaria retinopathy is a relatively recently recognized condition, and it is important in diagnostic way. For example, it has been found repeatedly that in hyperendemic areas to malaria is frequently overdiagnosed, and other causes of severe febrile illness are frequently overlooked. So it is important that if a patient presents with severe febrile illness, his fundoscopic examination should be done, and if unique retinopathy of malaria is not present, then other causes of severe febrile illness should be sought. This is also especially important that, as I have already told, that in hyperendemic areas, asymptomatic parasitemia is also common. So this makes the condition also complicated, and this frequently leads to misdiagnosis of other serious febrile illnesses. So this retinopathy especially should be looked for in severe malaria. This is the characteristic retinopathy. This shows perimacular whitening. This is the macula here, and you can see this white area surrounding the macula, and they are pale centered hemorrhages, which are also called Roth spots. Previously we thought that it was particularly specific to infective endocarditis, but now we know that these Roth spots can occur in other conditions like leukemia, severe anemia of any cause, and even cerebral malaria. So this combination of perimacular whitening and pale centered hemorrhages is very particularly specific to severe cerebral malaria. There are also certain chronic complications of malaria. Most important among them is tropical splenomegaly syndrome, also called hyperreactive malarial splenomegaly. This is an exaggerated and aberrant immune response against repeated infections in hyperendemic areas and manifest with massive splenomegaly, high IgM antibodies against malaria, and anemia. This is usually treated by antimalarial prophylaxis, and if the patient is having active disease, first treatment, then prophylaxis to prevent repeated infections, and it frequently is improved. But sometimes the condition becomes resistant to this treatment, develop into clonal lymphoproliferative disorder, which ultimately can evolve into a malignant lymphoproliferative disorder. So it should be treated early, as soon as possible when recognized. Another one is immune complex glomerulopathy, which presents with nephrotic syndrome, and usually it is associated with Falciparum malaria, Plasmodium malariae infection. Another unique association is with Burkitt's lymphoma and Epstein-Barr virus infection. We have seen previously that endemic form of Burkitt's lymphoma, that is unique to endemic areas of Africa and is caused by Epstein-Barr virus infection. This is highly prevalent only in areas where Falciparum malaria is prevalent. Diagnosis mainly depends upon Giemsa stained blood smears, which are the mainstays of diagnosis. Both thick and thin smears are made. Thick smears are more sensitive because you can examine large volumes of blood in single slide. Thin smears are more simple, and they are better for discrimination of parasite species. You can tell which type of infection is there, and it's not always apparent in first sample, and if the first sample is negative but the disease suspicion is high, then repeating the smears every 8 to 12 hours or 24 hours is appropriate. Alternatively, rapid, simple, sensitive and specific antibody based diagnostic stick or card tests are available for Falciparum specific antigens in finger pricked blood samples. They are very rapid, immediately provide the diagnosis, and are called RDTs or rapid diagnostic tests, but they have some shortcomings. Number one, they are a bit costly and not widely available, especially in those areas where Falciparum is more prevalent. And moreover, they do not quantify parasitemia, so we never know the burden of disease in this case. These are the photographs of the parasite in Falciparum in various stages of asexual development. A is young trophocyte, B is old trophocyte, C shows trophocyte with pigment, D is a mature schizonte which is about to burst, and E and F are female and male gametocytes respectively. And this is the thick smear showing trophocytes and gametocytes of the Falciparum respectively. Regarding treatment, we will first discuss the common antimalarials which are used. By far the most effective, the cheap and safest drug is chloroquine, and remains the drug of choice in areas where Plasmodium falciparum is sensitive to it, and for all other species. So it is the first choice if we know that in this locality Falciparum is not resistant or the species are other than Falciparum. Another alternative is amodiaquine, which is closely related to chloroquine and has similar characteristics. Mefloquine is effective against chloroquine resistant strains of Falciparum and also effective against other malarial species also. Another one is quinine dihydrochloride and quinidine gluconate. It should be remembered that quinine is the first ever drug to be discovered for effective against malaria, and it is still the most potent in that no resistance to this drug has been achieved anywhere in the Falciparum infection. So this is the first line therapy where serious Falciparum disease is suspected and should be started intravenously. Quinidine was better remembered as antiarrhythmic drug. It is an isomer of quinine and is equally as effective for treatment of malaria. and where available it should be given. Primaquine phosphate is a 8-aminoquinolone synthetic drug and is the drug of choice for eradication of dormant liver forms. This is the only drug which is effective against hepatic hepatocytes of vivax and ovale infection. Sulfadoxine pyrimethamine combination, which comes with the name of Fencidar, is usually effective for prophylaxis in malaria endemic areas. Artemisinin derivatives are increasing in role because they are very safe and they are effective even against resistant falciparum malaria and have very low toxicity. Atowacone plus proguanil, which comes with the fixed combination of Malaron, is highly effective for both the treatment and chemoprophylaxis of falciparum malaria. Certain antibiotics, especially doxycycline, is commonly used for falciparum malaria treatment in conjunction with quinine or quinidine. Halofentine is related to quinine and is effective against the erythrocytic stages of all 4 human species. And lumefantrine is related to halofentine and is available only as a fixed dose combination with artemether, which is an artemisinin derivative and comes with the name of Coartem. It has reliable efficacy against falciparum malaria. Now we will discuss the treatment under various situations. In areas where chloroquine sensitive falciparum malaria is present, and for the treatment of infection with Plasmodium malariae, means chloroquine sensitive falciparum and malariae infections. The treatment is with chloroquine phosphate 1 gram or 4 tablets given at 0 hours, then 500 milligram or 2 tablets at 6 hours, 24 hours and 48 hours. This is a total of 10 tablet course and it completed in 48 hours. Now the treatment of Plasmodium vivax and ovale infections. In this case, chloroquine is given similarly as above, that is 10 tablet course, and this should be followed by a 14-day course of primaquine 30 milligram base, which is 2 tablets daily for 14 days. This is for eradication of hepatic hepatocytes which can occur in vivax and ovale infections. But it should be remembered that before giving primaquine, the patient should be checked for G6PD deficiency, because in that case he is likely to develop severe hemolysis. Then for uncomplicated infections with chloroquine resistant falciparum malaria, it should be remembered that resistant falciparum malaria should always be treated with the combination of at least 2 drugs, because it should avoid the development of resistance to other drugs as well. So drug of choice is Coartem, which is a combination of artemether 20 milligram and lumefantrine 120 milligram, 4 tablets twice daily for 3 days, 6 dose course. But now we have 4 tablets which contain equivalent of 4 tablets, that is 80 milligram of artemether and 480 milligram of lumefantrine, and this 1 tablet can be taken twice daily for 3 days. Alternative is Malaron, which is a combination of atovaquone or proguanil, and the third alternative is quinine sulfate 650 milligram 3 times daily for up to 7 days, but it should be associated with doxycycline 100 milligram twice daily for 7 days or clindamycin 600 milligram twice daily for 7 days. So always a combination should be used for a resistant falciparum malaria. Now with severe or complicated infection with falciparum malaria, in this case this is a medical emergency and oral drugs are not recommended. Always should be started with the intravenous drug, injectable drugs. And drug of choice nowadays is where available intravenous artesunate in a dose of 2.5 milligram every 12 hours for 1 day, followed by once a day for 2 days. This is a total of 4 doses. If artesunate is not available, then the alternative is quinidine gluconate 10 milligram per kg intravenously every 12 hours, or quinine dihydrochloride given as 20 milligram per kg intravenous bolus, followed by 10 milligram per kg every 8 hours, and this should be continued as long as the patient is very sick. Another alternative is artemether 3.2 milligram per kg intramuscularly in a single dose, then 1.6 milligram per kg per day intramuscularly. And it should be remembered that these injectable drugs should be continued as long as the patient is sick, and immediately as the patient recovers and is able to tolerate oral, these regimes should be converted to oral drugs. So this is the situational treatment of malaria according to various situations. Now we will briefly discuss treatment of severe or complicated malaria, which is usually due to falciparum, because this is a serious disease and does not only require antimalarial but certain other ancillary treatments are also required. Severe disease, which is usually due to falciparum infection, is a medical emergency and requires intensive nursing care and careful management. So, as I already told, intravenous artesunate is the drug of choice. Alternatives are intravenous quinine and quinidine, and these patients are usually dehydrated because of poor intake, and they may have diarrhea or vomiting. So careful fluid resuscitation is required, and this is very critical because while overhydration can cause non-cardiogenic pulmonary edema, which is a serious complication, underhydration can lead to hypotension and pre-renal azotemia. So it should be very carefully calculated that how much fluid is required for proper resuscitation. This is also important to remember that sometimes in these severely sick patients, hypotension can develop even without dehydration. So all these points should be kept in mind, and careful fluid resuscitation should be done. Then blood glucose level should be measured every 4 to 6 hours for all unconscious patients, because hypoglycemia is quite common in these patients, and when found it should be treated with intravenous 50% dextrose. Hypoglycemia if found, then it should be always suspected that is commonly associated with metabolic acidosis, which is actually lactic acidosis, and it carries a poor prognosis. Severe anemia in these patients should be treated with fresh blood or packed red cell transfusions. And if the patients have renal dysfunction, then early institution of hemofiltration or hemodialysis can improve prognosis. Acute pulmonary edema is usually non-cardiogenic, but fluid restriction and diuretics are usually helpful. But if these immediate measures fail, then early institution of positive pressure ventilation by a mechanical ventilator should be started. These patients have a propensity for spontaneous bleeding, and these cases should be treated with either fresh blood or intravenous vitamin K. Fresh blood because it also carries with it the coagulation factors. This provision is not there for stored blood, so only fresh blood is the option. Convulsions, especially in adults, are usually indicative of CNS involvement and should be treated with intravenous or rectal benzodiazepines. And in all unconscious patients who are having convulsions, aspiration pneumonia should be suspected and appropriately treated. And very important point that frequently gram-negative septicemia occurs in these patients and should be recognized early. And it is sometimes recommended that treatment with both antimalarials and broad-spectrum antibiotics should be started from the outset, especially in children in hyperendemic areas. Prevention of the disease is by various means. First of all is vector control by improving the sanitation or insecticide sprays. Then use of bed nets and mosquito repellents to avoid bites by infectious mosquito. The travelers from non-endemic areas to endemic areas should always avoid mosquito bites and should take chemoprophylaxis as long as they are at risk of developing infection, because in these non-immune people, usually the disease is very serious. These are the various means of avoiding mosquito bites, especially mosquito nets. This is the usual different types of malaria prophylaxis. Chloroquine is the drug of choice where resistant falciparum is not a risk. The dose is 200 milligram or 2 tablets every week. Otherwise, if there is risk of acquiring multi-drug resistant falciparum, the choice is Malaron, which is a combination of atovaquone and proguanil. Another choice is mefloquine, also in chloroquine resistant falciparum, which is 250 milligram per week. or doxycycline also for multi-drug resistant falciparum, which is 100 milligram daily, or primaquine, which should be given for eradicating hepatic hypnocytes where chances of Plasmodium ovale or vivax infections is there, because these cause recurrences. If the patient returns after several months, it can cause recurrence. The next topic, Amebiasis, inshallah we will continue next week.